Hello everyone, welcome to the Weekly Delights episode number 2. We are going to discuss antibodies in rheumatology in this session. Now, the basic motto of this session is not only to know and remember the different antibodies which come under rheumatology section, but also to understand how they are clinically oriented and how we are going to use these antibodies in our day-to-day practice in order to be an efficient physician, right? So let's start with the session. The first thing I want you to be really good at are basics. So first basic thing I want to tell you is going to be what is actually a rheumatic disease. So rheumatic disease is a disease which is simply an autoimmune disorder. So a rheumatic disease is simply an autoimmune disorder. So basically, when it comes to an autoimmune or a rheumatic disease, how do you basically identify that it is a rheumatic disease? So simple thing is that any patient coming with recurrent febrile illness. What does this mean? That means a patient is having fever for more than or equal to 3 times a month. More than 3 times a month. This is recurrent febrile illness. This is such that there is no established infectious etiology. That means a patient is having recurrent episodes of fever, but you are not able to establish any specific infection associated with that recurrent fever episodes. That will be called as a rheumatic disease. Now, when you know that this is a rheumatic disease, how do you actually classify them? So the next thing is how to identify which group of disease this is. So if you look at any rheumatic disease, when you look at any rheumatic disease, it could be fitting into 3 categories. It can fit up into 3 categories. First category is a lupus group of diseases. It is a lupus group of disease. What do you mean by a lupus? Lupus means a wolf-bitten form of a rash. So a wolf-bitten form of a rash is associated with it. So lupus group of disorders will be disorders in which rash will be a predominant feature. What will be those disorders? Those will be like systemic lupus erythematosus, scleroderma, Zika syndrome, mixed connective tissue disorders, and lupus. These will be the lupus group of disorders, right? Then you have the disorders where arthritis will be predominant. So that will be the arthritis group of disorders which will predominantly have arthritis as a component, which could be inflammatory arthritis, which could be very important, that is rheumatoid arthritis, right? It could also be spondyloarthropathies. So that is what is going to be the fact. And third and not the thing is going to be vasculitis. The last but not the least is vasculitis. Now what do you basically mean by vasculitis? Vasculitis will be inflammation of blood vessels. So vasculitis will basically present with some blood vessel related manifestation, which will be predominantly vasculopathies, headache, some limb pain, or what we call as the claudications. These different form of manifestations will be associated with it. So when you know that it is possibly a case of rheumatic disease, it could either be predominantly a rash, or it predominantly having arthritis, or predominantly a vascular disease. So this is how you are going to classify a specific disease. Now, what is going to be your approach towards the disease? Okay, so how you are going to approach? Now the first thing that you already know is that this is a rheumatic disease. You already know that this is a rheumatic disease. you are going to look at the prominent clinical features. You are going to look at the prominent clinical features, right? Once you get the prominent clinical features, based on that you will get either a lupus group, or it could be arthritis, or it could be possibly vasculitis, right? But before going to each of them, you need to be confirmed that this is a rheumatic disease. So how do you do that? You do that using a screening test. So now what is going to be a screening test to know that it is a rheumatic disease? So the screening test which we use is going to be anti-nuclear antibody, ANA. This is anti-nuclear antibody. This is in fact the most common immunoglobulin found in autoimmune disorders. So remember, about in 98%, more than 98% of the diseases, more than 98% of the autoimmune disorders, anti-nuclear antibody is found in. So we can conclude that ANA, this is the most sensitive antibody also. So when you are suspecting it to be a rheumatic disease, first step that we are going to do ANA. If you are getting ANA positive, this tells that this is going to be an autoimmune or a rheumatic disease, right? That is going to point towards that. But further way, how do you classify that? So basically, when it comes to your ANA, how do you actually test an ANA? That is the concept we need to do. So when you are testing your anti-nuclear antibody, it could be either a qualitative test or it could be a quantitative test. A qualitative test will be ELISA, which will give either to be a positive or negative. So this becomes a non-specific test. Whereas quantitative test, we could do either, we can do titers. If the titers are more than 1:160, this is considered to be significantly positive. Very, very important question when it comes to ANA screening. How much titer is significantly positive? More than 1:160 is positive. The second thing which is more commonly done is immunofluorescence pattern. The number of cells showing the maximum immunofluorescence pattern will be counted for a positive screen of that type of anti-nuclear antibody staining. So what comes under that? You will be having these predominant types of immunofluorescence, right? If you look at this first antibody, the homogeneous type of immunofluorescence staining, you can see on the left there is a representative diagram, on the right there is the exact immunofluorescence image. Let's magnify this a bit and go to our main concept over here. That is, in a homogeneous variety, you see homogeneously distributed immunofluorescence. Look at the right side, you can see that there is a homogeneous distribution of all the cells of immunofluorescence. Let's go further down to the speckled one. When you go to speckled, you can see the speckled immunofluorescence, a very fine granular immunofluorescence, right? Fine granules like immunofluorescence. This is called speckled immunofluorescence. Third type is centromeric pattern. Centromeric pattern occurs because of the antibody being stained during any specific phase where centromeres are predominant. This is how you can see. Just appreciate on the right sided image, Can you appreciate these two big cells in the center where all the antibodies are being stayed in the center, where all your centromeres are being aggregating? This is what is the centromeric pattern of immunofluorescence. And last but not the least, you are going to have nucleolar pattern. Nucleolar pattern looks like a very coarse, large globule-like immunofluorescence of the nucleoli. Can you appreciate this on the right side? Yes. This is what is going to be your different types of immunofluorescence. Now, how they are related and what is their clinical significance? Homogeneous immunofluorescence is given basically by two type of antibodies. One antibody is anti-double stranded DNA antibody and anti-Smith antibody. Okay, this is given by anti-double stranded DNA antibody and anti-Smith antibody. Anti-double stranded DNA antibody, remember, this is the most common antibody in SLE. First MCQ. Most common antibody in SLE is anti-double stranded DNA antibody, but anti-Smith antibody, this is the most specific antibody of SLE. We already have discussed what is the most sensitive, that is anti-nuclear. Most specific is anti-Smith antibody. Next you have speckled type. Speckled type you get because of A and B type of fibrillary proteins in between. This occurs because of SSA, SSB antibodies, which are SSA is also known as anti-Rho and SSB is also called as anti-Ra. This anti-Rho and anti-La are associated with Zika syndrome. Whereas a centromeric pattern of anti-nuclear antibodies is seen with anti-centromere antibodies. Very simple to remember, anti-centromere antibodies, and this is associated with localized systemic sclerosis. Whereas the nucleolar pattern occurs because of anti-topoisomerase 1. This is associated with diffuse cutaneous systemic sclerosis. So this is the entire table which we need to know. जब हम screen करेंगे, at the time of screening, you will get these different patterns of immunofluorescence. Homogeneous by anti-dsDNA or anti-Smith antibody related to SLE, speckled by anti-Rho and anti-La related to Zika syndrome or Sjogren syndrome, centromeric associated with anti-centromere, localized cutaneous scleroderma, and nucleolar pattern by anti-topoisomerase antibody, diffuse scleroderma. I hope everything is clear. Now the next step which we need to basically worry of, what type of screening we need to basically go for. So the screening will basically determine what predominant symptoms are. We have already seen. Now if I am getting rash, skin rash as the most predominant symptom out of the spectrum of symptoms and signs which I have, clinical features are spectrum of clinical features out of which rash is the most predominant feature, then it will be lupus group of disorders. The first lupus group of disorder is going to be systemic lupus erythematosus. So let's quickly fill out the tables and everything is simply sorted. The first antibody I want you to know is anti-Smith antibody. We already know what is related to anti-Smith antibody is that anti-Smith antibody is basically the most specific antibody for SLE. This is the most specific antibody for SLE, but at the same time this is only seen in 10% of individuals. So basically it lacks sensitivity, and that's why it is not preferred. The second antibody is anti-double stranded DNA antibody, anti-dsDNA antibody, which is basically associated as the one of the highly sensitive one, though not most sensitive but highly sensitive one, and that's an antibody which is associated with prognosis, right? So if you want to assess the prognosis of our patient, which antibody we are going to look for? We are going to look for double-stranded DNA antibody. Then you have the third antibody which has been recently been included, that is antiphospholipid antibody, which is APLA. Now what is this APLA? Now APLA is a antibody against beta-2 glycoprotein 1, and this is associated with thrombosis, risk of thrombosis and recurrent abortions. Whereas the fourth antibody, that is the antihistone antibody, you can remember histone related to drugs. So remember, whichever drug induced SLE is going to be there, it is antihistone antibody. Next, the next antibody which we are going to see is anti-Rho and La. Now remember, this antibody is not specific. This can be seen in Zika. So this is basically diagnostic of Zika, but can be seen in SLE. Now what is the basic role? Anti-Rho and anti-La, these are large molecules. So as these are very, very large molecules, they are not going to cross the glomerular basement membrane, and that's why there is a lesser risk of nephritis in the patient. There is a lesser risk of nephritis in these patients. Next antibodies that we need to basically know is anti-ribosomal P antibody and anti-neuronal antibodies. Now what are these? Ribosomal P से याद रखना है, P for neuropsychiatric, P for psychiatric. So increased risk of neuropsychiatric disorders or neuropsychiatric pathologies like convulsions and psychosis, CNS lupus is ribosomal P. And neuronal से neuropathy याद आनी चाहिए. This is associated with peripheral neuropathy. Right? Then you have the next antibody, that is anti-erythrocyte antibody, which is associated with hemolytic anemia. So that is all about the antibodies which we see in SLE. Let's go to other lupus group of disorders. So done with systemic lupus erythematosus, let's go to other lupus group of disorders. Anti-centromere antibody is associated with localized scleroderma. We have already seen this. So if someone asks you, CREST syndrome is associated with which antibody? Anti-centromere antibody, because it's a localized type of scleroderma. If you are being asked anti-topoisomerase antibody, which condition is it associated with? It is associated with diffuse scleroderma. Next remaining are two antibodies which are RNP antibodies. One is anti-U3 RNP antibody and anti-U1 RNP antibody. Now tell me, one is specific, is the highest one, so it will be specific. So remember, U1 RNP is specific antibody for mixed connective tissue disorders, whereas U3 RNP is having prognostic role in systemic sclerosis. So if a patient of systemic sclerosis comes, the titer of anti-U3 RNP antibodies will decide whether the prognosis is good or bad. So once we are done with lupus group, we have the arthritis group of disorders. If we are having a patient with predominantly arthritic symptoms, the most prominent type of arthritis which you should think of is rheumatoid arthritis. The first antibody related to that is rheumatoid factor. What is this rheumatoid factor? This is a immunoglobulin M against the Fc portion of immunoglobulin G. This is your rheumatoid factor. This is basically the best screening test for rheumatoid arthritis. Why? Because this is not specific. This can be associated with many other conditions. Nextly, we have the anti-CCP, that is anti-cyclical citrullinated protein antibody. This has the diagnostic role in rheumatoid arthritis. This is most specific and is having a diagnostic role in rheumatoid arthritis. Last but not the least, you have vasculitis group of disorders. That means mainly the vascular manifestations like claudications, headache, weakness, ischemia of the limbs, infarction or gangrene of the limbs. This will be prominent. So when it comes to such symptoms, you are going to think of vasculitis. So two type of vasculitis antibodies we know. One is C-ANCA antibody, which acts against anti-proteinase 3. So this is basically an anti-proteinase 3. This is antibody against proteinase 3. This is one. The second one is P-ANCA. P-ANCA is associated with anti-myeloperoxidase. So this is anti-myeloperoxidase, an antibody against myeloperoxidase. Which conditions do you get this with? So basically, C-ANCA antibody is associated with Wegener's granulomatosis, whereas P-ANCA antibody is associated with microscopic polyangiitis. These are the most important antibodies which you should basically know of. Remember, here there is a point of confusion, so just to heal that, remember P for polyangiitis. So C automatically becomes Wegener's granulomatosis. So C-ANCA is associated with Wegener's, P-ANCA is associated with microscopic polyangiitis. That's all for today. See you in the next week.